Mi nombre es Italo Campomanes, bienvenidos a Psicología Basada. Hoy tenemos una invitada muy especial y bueno, quiero agradecerle desde ya por su disposición y por su tiempo. Y bueno, hoy vamos a hablar sobre la terapia dialéctico Conductual. Uh, my name is Italo. Welcome to Psicología Basada. Today we have a very special guest, Sheri Van Dijk. I want to thank her for her willingness to be here. We are going to talk about dialectical behavior therapy. Hi, Sheri.
Good evening.
Okay. So, the first question is, what led you to become interested in DBT and eventually adapt it into a more flexible model?
Yeah, so I was fortunate in that I was doing my master's degree placement at a hospital where they were just in the middle of starting up a DBT, an almost DBT program, I call it. So they were starting up a DBT program, not a full program. And so in my placement, I got to learn with them about DBT and was involved in the startup of this program, and was eventually hired on at that hospital and was able to continue working in the DBT program. Most of my work actually stemmed from that and from the fact that so many of our clients were unable to access DBT resources in our area. And so it was really a matter of necessity that caused me to kind of start adapting DBT and kind of strategizing about how I can bring some DBT to my clients who really needed the therapy. So we didn't have a lot of resources at that workplace, to provide a full DBT model for folks. And so that's really what led to me adapting the model to fit with my clients and what their needs were.
Okay, my microphone. Okay. And in your clinical experience, what patient needs did you notice weren't fully addressed by the standard DBT protocol?
Yeah, so kind of like I was saying, it was really about not so much about the needs of the clients not being met by the standard protocol, but the lack of services that were available to clients. So that's really where my drive came from, to modify and adapt DBT to make it more accessible to people. And I think really, over the years, DBT has become more accessible with more clinicians providing either DBT or DBT-informed therapy, but there's still really a scarcity of clinicians. I was actually just talking to a fellow therapist today who was trying to find a DBT therapist for herself, and she's really struggling to find someone. So, I thought that spoke volumes to the fact that we need more therapists bringing DBT into their practice. I think it's a very intimidating model because it is so comprehensive. It's kind of a double-edged sword. It's a great treatment because it's so comprehensive, but I think that's what also scares clinicians away from it because the training is so intensive and so on.
Okay. About your book, DBT Made Simple, sorry.
Right.
What's the central idea?
In that book, yeah, the central idea really is to make DBT more accessible to clinicians. So that's my book that was written for fellow clinicians to kind of demystify it, to break it down into smaller pieces. I remember when I was doing my initial training in DBT years and years ago now, in the early 2000s, and I found that so many of the workshops that I was attending, they were all about the theory, which of course we need theory when it comes to the practice that we're doing, the treatment modalities that we're using. But DBT skills are quite complex as well. And there wasn't a lot of, the meat of the skills, how to use the skills, how to teach the skills to clients. And so my goal with DBT Made Simple was, to bring many of the principles that are important for us to know of as clinicians, the biosocial theory, for example, talking about behavior theory and what a big part of DBT behavior theory is, but also to introduce clinicians to many of the DBT skills and make those more accessible to folks. So that was really the goal behind DBT Made Simple.
Okay, thanks. In your book, you have said that a little DBT is better than none.
Mm-hmm.
What does that look like in clinical practice?
Yeah. So that's a good question. And like many of my answers, the part of the response to that is it depends on the client. So a little DBT is better than no DBT is really just referencing, again, the lack of resources that I've been faced with in my location. When I can't get someone into a full DBT program, even when that's my preference, let's say they have to wait sometimes for 2 years to get into a full program. I might think that this person could really benefit from a full program, but we just can't access it. And so some DBT is going to be better than no DBT. I might work with that person until they're able to get into a full DBT program. Especially someone who has a diagnosis of borderline personality disorder, or they're self-harming or having a lot of suicidal thoughts. That's someone that typically would need a full DBT program. Many of the clients that I work with don't actually need a full DBT program and that intensive resource program, right? And so in that case, some DBT is better than no DBT in terms of the skills and the validation that's being provided and teaching the client how to validate themselves. Like, there's so many valuable tools in DBT. So there's kind of a couple of different perspectives there when I say that.
Okay. How does your version of DBT differ from Marshall Linehan's full model in terms of structure, time, and tools?
Mm-hmm. Yeah. I think the way I practice DBT or use DBT in my practice is I'm more dialectical in my DBT approach. I'm just more flexible with it. So I remember, especially way back in the early years when I first started practicing DBT, Marsha Linehan and her kind of team, their mindset was very much, if you are not doing these 4 things, all, the different components of DBT, if you're not doing all of this, then you're not doing DBT. Now, I agree, we need to be open and, provide fully informed consent to our clients. If I'm not doing full DBT, I need to let them know what I'm doing compared to what a full DBT program is. But at the same time, I don't think that many individuals need, again, that resource intensive program. And so the way I practice DBT, in my early years of my career, especially, I would try to kind of bring as much of a DBT model to someone as I could. So, I would do phone coaching. I had a DBT consultation team of sorts. So I tried to be as close to the model as I could, given that I was an individual clinician in private practice. But we can't provide that level of service to every client, especially when we're in private practice, or I'll speak from my own experience. I can't provide that level of service. So I pick and choose nowadays, what does this client need and what am I able to provide for them? And again, bringing in the idea of fully informed consent. I let my client know this is a full DBT program. This is how I practice and what I'm able to provide.
Mm-hmm. Okay. About DBT skills, which DBT skills do you find most useful when working with depression or anxiety?
Yeah. So again, it depends on the client, right? Because even when we have a diagnosis of depression or anxiety, it looks different for different people. But generally speaking, usually I would say mindfulness, the core mindfulness skills, teaching mindfulness, teaching the 3 states of mind, the DBT states of mind. That's one of my favorite skills that I use usually fairly early on in treatment with almost every client. So I would say mindfulness is really a big skill. It's really one of the foundational skills, if not the foundational skill in DBT, because, in order to learn to name emotions accurately, for instance, you need to have the ability to observe and describe your emotions. So it really is setting the stage for skills usually that are going to come later. So yeah, I would say usually mindfulness and states of mind would be two of my favorite go-tos for folks with depression and anxiety. And many other problems and disorders as well.
Okay. When you are in therapy, how do you decide which skills to teach first? And how do you adjust the approach to fit each client's pace?
So how do I decide which skills to teach first? Again, usually because mindfulness is so foundational, with most clients, I go with mindfulness first. Sometimes I'm finding, especially nowadays, we don't even have to, teach in-depth mindfulness to clients. They already often have a basic knowledge and understanding of mindfulness nowadays. But I almost always will start with mindfulness. The exception to that, though, would be if I have a client who has a lot of self-harming urges, behaviors, suicidal thoughts. So when there is, in DBT speak, the life interfering behaviors like that. But also if I have a client where something like substance use, for instance, is causing concern that they might not stay in therapy. So I might not, if I can't get the client to stay in therapy, I don't have much chance of helping them. So usually those categories, I will go with distress tolerance skills first in order to start providing some replacement behaviors for the client so that we can reduce the life interfering and the substance abuse or use behaviors. So that's kind of where I start at. So, assessing the client, I sometimes will teach mindfulness skills of some sort, but again, whether that's the states of mind or mindfulness more generally, I might teach that in a first session. And then see how the client does. Of course, we're always giving homework in DBT. So I want to check in on how are they doing with the skills, making sure that it's still the rationale for the skills is still making sense for them in terms of the goals that they have come into therapy with and so on. And this is also how I set the kind of adjust my pacing, as you were asking about, for the client, right? If I see that this is a client who's got some mindfulness practice or they've really taken to mindfulness quickly, then I'm going to move things along a little bit. If they're not really getting it, then that's where I'm going to slow things down, do some practices in session with them, make sure that they're doing their homework, assessing for things that might be getting in the way of them remembering to do homework. So, those are kind of the indicators of pacing. How well are they doing practicing skills? Are they understanding the skills? Knowing, of course, that generalizing the skills is going to look different for different people. That, the individual may be able to speak to the skills in session, and they might know their skills like this as we go along, but are they actually practicing them when things are getting tough, right? So that will be another indicator for me. Do we need to slow things down, or can we keep going at the pace we're going at?
Okay. We were talking about mindfulness. So in your words, what is mindfulness?
I think these are actually John Kabat-Zinn's words that I use, but mindfulness is when we are doing one thing at a time in the present moment with our full attention and with acceptance. Now, I actually have a quite general way of teaching mindfulness. And then, of course, there are also the DBT core mindfulness skills where we might break mindfulness down into smaller, kind of more bite-sized pieces. I refer to this as observing, describing, participating, right? But again, this is where I get a little flexible. Not every client needs that breakdown. And pacing-wise, I can teach one skill in session, or I can spend time teaching 3 skills in 1 or 2 sessions. So, I often go for the more abbreviated version, making sure that it makes sense for the client that I'm working with. If it's not making sense, let's say I have a client who's a more concrete kind of client, they struggle with that abstract idea of mindfulness. Observing and describing is a really nice way of breaking it down into smaller steps for the client to make it more understandable.
Okay. What common mistakes do you see therapists make when trying to apply DBT without full formal training?
So, I think I'm not so sure this is about therapists without full formal training in DBT, is just therapists generally making the mistake of not being flexible with clients. So let's say, I'm primarily a DBT-informed therapist. If I'm really stuck on teaching the skills and teaching them in this particular order and, going at this particular pace because this is what the manual says, right? I might be missing things from the client, in terms of cues regarding attunement with the client. I work with a lot of folks with developmental trauma, with complex trauma, and I do find that we need to be flexible especially with those clients, in order to create a safe space for clients. We need to, again, pacing, we need to make sure that we're leaving enough space in session for the client to get their need of the week met, as well as for me to meet the client's needs with regard to new skills, right? So really finding a balance there. So I don't know that that's a specific, DBT therapist skill, is just a general therapy skill, but it is a mistake that I see consultees make. And it's a skill that a mistake rather, that I've made myself with clients. I have my agenda, and sticking to my agenda can actually cause a rift in the relationship. So I think that's a mistake all of us make at some point.
What is validation?
Validation is where we can indicate to the client that we either understand their experience. I'll stick with emotions just for simplicity, so I can understand why you feel the way that you're feeling. Or if I can't understand it, that I am accepting the emotion that you're expressing. So it doesn't mean that we like what's happening. It doesn't mean that we agree with it. It means that we are able to acknowledge it and essentially let the person have their emotion. This is actually a conversation I often will have with clients around when their environment is invalidating them. One nice way of thinking of this is ask your partner, for example, to just let you have your emotion. Don't try to, take my anxiety away. Often, caregivers they have the best of intentions, but telling someone to calm down when they're feeling anxious usually isn't helpful, right? So, validation is about allowing the person to have their feelings, not minimizing them, not ignoring them, not trying to avoid them, but also not jumping straight into problem solving and trying to get the emotion to go away, right? So that's kind of validation in a nutshell.
Ok. Este video está auspiciado por nadie. Así que suscríbete, dale like, comparte. Realmente apoyas muchísimo haciendo eso. Dicho esto, puedes seguir con el video. Yeah, and about validation, what makes it so powerful in therapy?
Yeah, it is powerful. I actually refer to it, when I'm teaching about it, I refer to it as a superpower. And this is, validating others. So Dan Siegel is the neuroscientist, right, who talks about if you can name it, you can tame it, referring to emotions, right? And he's got this great, I think, a 3-minute YouTube video where he talks about, if I name your emotion accurately, so if I can accurately put the name on the emotion you're experiencing, and I love Dan's language. He says, your upstairs brain squirts soothing chemicals on your downstairs brain. So there's actually a physiological effect that validation is having where it's soothing for us, right? So if I'm faced with a client who's feeling angry and I can validate the client's anger, their anger is going to come down a couple of notches, presumably, you know, given the right circumstances. There's a lot of context here that needs to be taken into consideration. But ideally, in most instances, it's going to take the edge off the anger and soothe that client. So then we can move in a more therapeutic direction. We can go for skills. You know, would you be willing to use a skill, do some deep breathing, do something to re-regulate with me? When it comes to self-validation, I think it makes sense to me. I don't have the evidence for this or the research, the science behind it, but given what Dan Siegel talks about, it makes sense to me that self-validation has the same soothing effect on the brain. If I can name my emotion accurately, my upstairs brain is going to squirt soothing chemicals on my downstairs brain and help me feel more soothed from that emotion. But that, of course, means that I have to have the ability to name my emotions accurately. And a lot of the folks that I work with don't have that capacity, at least at the beginning of therapy.
And what strategies do you recommend for clients who come from highly invalidation environments?
Yeah, what strategies? So I actually like to teach the biosocial theory to clients when I'm hearing that this will fit for them. I think it can be very validating for them to understand that part of their experience is that high sensitivity that often people are born with, that emotional vulnerability that we call it in DBT. I use those two terms interchangeably, emotional vulnerability and high sensitivity. So I think it's very validating for them to know this is just something you're born with. It's part of your temperament, right? And yes, the environment plays a part as well. The good old nature versus nurture argument, right? Or challenge. So I find the biosocial theory very helpful for clients to learn about. And then really, again, validation, I think is a big skill for folks that have grown up in that pervasively invalidating environment. So I think that's a really helpful one. I mean, lots of skills, of course, as well. And again, depending on the client's specific situation, but that would be a consistent one that we would need to teach someone with that kind of history. I actually, again, I had this conversation with a consultee this morning. She was actually talking about Kristen Neff, who does a lot of self-compassion therapy. And we were having a discussion about how it's involved in DBT. And I said, you know, it's interesting because I don't think we actually, I've never heard Marsha Linehan use the word, and I've never read the word self-compassion in her manuals. But it is a big part of DBT, right? And so then I started listing off skills for her. I said, think about non-judgmental stance. When we're being non-judgmental with ourselves, which is a core mindfulness skill, when we're being non-judgmental, we're practicing self-compassion. When we're practicing mindfulness, I mean, part of mindfulness is acceptance. When we're accepting ourselves, accepting our experience, we're bringing compassion to ourselves. The skill of self-validation, like all of these things are really, we're talking about self-compassion without saying those words, which I think actually, for many of the folks that I work with, is a benefit that we don't use that language. I think it's actually, it can cause problems for many clients with developmental trauma, complex trauma. The idea of being compassionate to myself. What about the clients who say, well, I'm not worthy of that because that's what they learned, or, you know, I don't deserve to bring compassion to myself, or there's just, you know, a block getting in the way of them being able to do that. So when we can put it into concrete, and actually, as I'm saying that, I think the other thing is sometimes people haven't learned how to bring compassion to themselves. So we're operationalizing it for people. We're saying, here's a skill. We're not calling it self-compassion. We're calling it non-judgmental stance towards yourself, for example. But here's a way that you can be compassionate to yourself. So we don't use that language per se, but it's definitely a big part of DBT.
Okay. Okay, perfect. Have you personally used DBT skills in your own life?
Probably most days I use at least one skill, if not every day.
Okay,
Yeah, yeah, they're all over the place in my life.
okay. Is there one that especially impacted you as a therapist?
I love that question, and whenever someone asks me that, or like, do I have a favorite one? I kind of have it like a top four, I would say, which are probably mindfulness, and these are all intertwined. I would say probably mindfulness and self-validation and radical acceptance and non-judgmental stance. But then I also love the quick re-regulating skills. Marcia calls them the tip skills. I've actually added my own to the front of that. So I call them the F-tip skills, but they're a fast way of changing our body's chemistry to help us quickly regulate emotions. So those would, I think that's my top five.
Okay. For therapists who feel overwhelmed by the full DBT model, where would you suggest they start?
Where would they start? If they feel overwhelmed with the full model, I would say probably start by practicing skills yourself. Because I think, getting a good sense of what is this skill? How do I use it? That's obviously going to help you to be a more effective teacher of that skill. It's also great. Marsha Linehan used to talk about have good stories to share with your clients. So when we're practicing skills ourselves as clinicians, we're creating stories that we're going to be able to share with our clients that motivates them to use this skill, that develops trust and connection between us and the client when they hear about our own personal use of skills, and is going to build our confidence in this therapy.
Could you share an example or case where using just a few DBT skills led to a meaningful change?
Yeah, the one that stands out in my mind most is actually a client nowadays that I would actually probably treat a little bit differently, because I'm not just a DBT-informed therapist anymore. I do some trauma therapies in my practice. I've kind of, spread my wings a little bit. But this was a client that I worked with at my original workplace at the hospital I was working in. We were a brief therapy clinic, and so even though it wasn't the greatest thing for clients to have such a limited amount of sessions, it actually pushed me to be a more skills-focused therapist, which I think was helpful, because we only had 12 sessions to work with individuals. And this was a young woman who came to me with post-traumatic stress disorder after she had been burned. She had suffered, I think, third-degree burns on an arm because of a fire that she had been caught in. And I would say probably the skills that we used most with her was mindfulness to help with flashbacks, nightmares. We did things also like the nightmare protocol and those kinds of things to help with the nightmares. But very quickly, her flashbacks decreased in frequency. She became more able to manage the anxiety and, the PTSD symptoms when it was arising with the use of mindfulness and some of the other skills. And by the end of our 12 sessions together, she actually no longer fit criteria for post-traumatic stress disorder. So that was pretty cool and exciting.
How can DBT be taught in low resource setting?
Yeah, I think again that comes back to the flexibility, right? So when we don't have resources, that it pushes us to get creative and to really be more client-centered. What does this client in front of me need? What kinds of skills do they need most? Again, usually starting with mindfulness, because it's such a foundational skill. Or, as I said earlier, if there's the life-interfering behaviors or the substance use, then probably we want to start with distress tolerance first. But aside from those two things, it's really about, when I have a client who's lacking in assertiveness, really struggles with their confidence in communicating with others, then I don't necessarily need to teach them distress tolerance skills. They need some interpersonal effectiveness skills. Again, mindfulness to help them bring those other skills to bear. But so adapting, really helps us to be more client-centered, I think. So again, it's a double-edged sword. It's not great when we're lacking in resources, but it does push us to really be client-centered and, look at the client in front of us and determine what their needs are and how we can best meet them. Did that answer your question?
Yeah.
Okay.
What are the strengths and limitations of teaching DBT skills?
Teaching in individual sessions,
Yeah.
the way I do.
Yeah.
So, again, the strength of that is that we're so client-centered, right? So if someone doesn't need distress tolerance, I don't need to go there with them. They don't need to sit through 12 groups or 8 group sessions of distress tolerance. The limitations, though, it can be a struggle for us as clinicians when we have a client where, we're trying to deal with maybe the crisis of the week on an ongoing basis. So many of our clients, again, if they're suicidal, if they're self-harming, maybe they've been to hospital in between sessions, we're trying to address that particular crisis. It's hard to get to the skills training, right? And this is why, of course, one of the reasons why Marsha Linehan developed the different components of DBT, to separate out the skills training from the individual work so that we didn't have to face that challenge. But when we have to face that challenge because we don't have the ability for a client to be doing individual and group at the same time due to limited resources, we've got to get creative, right? So I would say that's probably the biggest challenge. But the biggest strength of teaching skills in session in individual is that we can really create the therapy that the client needs.
What message would you offer to people who feel like their emotions are too much or out of control?
Yeah. What message would I say to them? I would say your emotions are what they are. And welcome to the human race. I think we all get there at times, right? Some of us more than others, right? Some people are kind of on the other end of the spectrum and aren't in touch enough, of course, with their emotions. But if you're getting the message that you're too much or your emotions are too big, yes, it can be a challenge to manage those emotions. And I think a big part of that is accepting that this is part of who you are and being more emotionally vulnerable, or highly sensitive, as I like to call it. Yes, it does have its drawbacks, but there are also positives to it, right? Where people feeling more deeply, it certainly hurts more, but you also feel the pleasure more deeply when there are pleasurable experiences happening, the love, the joy, and so on, right? So I guess the short version is practice acceptance.
And for therapists new to this approach, which of your book would you recommend they start with?
So I think I'm trying to think now. When DBT Made Simple was published, I think it was 2012, maybe. So yeah. It is getting a little outdated, but I think it is, the messages in there are still very relevant. Marsha Linehan's book, of course, is the Bible of DBT, but it also can be a little overwhelming. Oh, great. Thanks. Marsha's book it's big, and I find, and I've had feedback from consultees that it can be overwhelming. So if you do want, the full thing, then certainly Marsha's book is a good one. There are a lot of publications, a lot of really great, helpful workbooks out there. My most recent one, I think that probably is a good one for skills teaching, would be the DBT skills workbook for emotional relief. The DBT workbook for emotional relief. And that one was published 2022, I think.
Okay.
Yeah.
Um, are you currently working on any new project or publication?
So not currently writing any books. My last book actually was published last December, which was the DBT workbook for complex post-traumatic stress disorder. And I'm teaching courses regularly and doing that kind of stuff. Nothing in the works writing wise right now. I think I've written, I'm trying to think, 11 books, I think is my total right now. And I'm not sure that I have anything left to say. So, but I continue to teach and I enjoy doing workshops and helping folks out, learning the skills and so on, and podcasts and other things as well. So this is kind of my ongoing project now.
Okay. And I told you I'm from Peru.
Mm-hmm.
So the last question is if you have worked for Peruvian psychologists in general.
Have I worked with Peruvian
Yeah.
psychologists
Mhm.
or
Yeah.
therapists? I have done a workshop for, I can't remember the name of there is a psychology agency in Peru that I've done a workshop for, and I have another one booked for them in the fall. There's actually two of them that I'm scheduled to do, two different agencies. I can send you the names of them if that's helpful, Italo. Because I don't know the names of them off the top of my head because they're in Spanish. Yeah. But yes, so I haven't worked directly with therapists, but I have done some workshops for them.
Okay. Maybe one is I remember Ruwainuna.
Yes, I believe so.
Well, Sheri, really thanks for being here.
Yeah.
And that's all for today. Um, Again, thanks very much. And thanks to everyone who stayed with us until the end. Goodbye.
Thank you.